Good day, everyone, and welcome to the ISMP webinar, Refocusing on Medication Safety, Best Practices for Injection Safety. My name is Chris Mahalik. I'm a medication safety specialist at ISMP, and I will serve as your webinar host and speaker. I'm delighted to be joined today by my colleague, Michelle Mandrak, Director of Consulting for ISMP. We've learned a lot navigating our way through the global COVID-19 pandemic, and as we continue to define what will become our new normal, it's imperative that medication safety efforts remain in focus. We know that more than 90% of hospitalized patients will receive some form of intravenous therapy, either by infusion or IV push administration. We know IV medications are clinically advantageous due to their immediate therapeutic effect, and patients that we're treating for COVID-19 often require multiple high alert IV medications. Today's webinar will focus on the challenges of the global COVID-19 pandemic, how practitioners can refocus on best practices related to IV push medications in adults, and how these strategies can have additional workflow benefits. Today's webinar is supported by Fresenius Kabi, and I'd like to thank them for their generous support of this program. Next slide. Before we begin, just a few housekeeping details. This activity is approved for 1 contact hour in states that recognize ACPE providers for pharmacists and for pharmacy technicians. If you are a nurse looking for continuing education credit, the information for that can be found on the ISMP website, ismp.org, which the address is located on the bottom right-hand corner of each of our slides. Next slide. Neither of the speakers today have any relative commercial and/or financial relationships to disclose. Next slide. In the materials that you received today for this program, they include the slide sets as well as instructions on how to obtain pharmacist and pharmacy technician continuing education credit. At the end of the program, we'll be giving you the attendance code that you're going to need to complete the online evaluation for continuing education credits. You'll need to log on to the web address shown on this slide with your login and username and password. And you'll need to do that by January 14th of 2022. And again, we'll share the attendance code at the end of the program. Next slide. Following the completion of this activity, our goal is that all of you will be able to identify how stressors, such as the pandemic, challenge medication safety efforts. Considering pandemic-related disruptions, you'll be able to list strategies to prevent medication errors, including the use of ready-to-administer preparations. You'll be able to describe 3 best practices for the use of IV push medications. And you'll be able to explain how best practices for IV push medications can provide additional workflow benefits. Next slide. And one more slide, please. So let's get started. In the early stages of the pandemic, this was really characterized for healthcare practitioners by a lot of questions and a lot of practitioner to practitioner sharing. In the medication workflow, the related issues really included trying to limit our exposure and transmission of COVID. We focused a lot around cleaning. We had a lot of questions related to medication movement, use of automated dispensing cabinets, how we should refill them. We did some medication delivery changes, all in this question phase where we were really unsure of how the virus was getting transmitted. We saw a pause in elective care. We moved towards more telehealth care. We experienced extremes in drug shortages. If you think back to those early stages, that the need for more meter dose inhalers, then moving into critical care drugs in short supply, where we were calculating days supply and in even some cases hours of supply left in our organizations. And at the core of all of this was really us trying to conserve the limited resources that we had. We had practitioners with changing responsibilities, practitioners caring for patients or different patients that they hadn't typically cared for before, doing jobs that they had not done before or had not done in a while. In some cases, we even had nurse runners, if you will, that were removing medications from storage locations and handing those medications off to nurses who were caring for patients so that they didn't have to doff PPE. Next slide. As we began to settle in, we recognized that we probably needed to keep track of medication safety risks associated with caring for COVID-19 patients. And we saw organizations begin to tag events in their reporting system that could be related to COVID. And these events were then shared as a weekly summary or daily summary, some brought to the command center so that they could be addressed. We saw practitioners eliminate or modify different workflow steps. I mean, there was a lot of concern around donning and doffing personal protective equipment at the same time trying to deal with supply issues. And we're still seeing these workflow changes today. Still more practitioners needing to don PPE to care for patients than pre-COVID. And again, I think we're still defining that new normal, things that we may have stopped doing, things that we gave up doing, things that we continue to do, and areas where we still have risk. You know, one of those is the independent double check process that occurs in healthcare. Some people are still doing them. Some people stopped. There was a cut down in the number of medications for which we performed a double check. And some just changed the workflow of how they implemented this mid-level safety strategy due to the need for practitioners to stay donned in PPE. Next slide. Right now, we're dealing still with vaccination and the vaccination process. We're tracking positivity rates and surges. If you look at last year compared to this year, in 2020 at this time, we had new COVID cases rising in 46 states. Interestingly, on the week of November 24th, we had COVID cases rising in 37 states. If you think about last year at this time, there were no vaccinations authorized by the FDA. And as November 23rd, we had 69.5% of Americans having received at least one vaccine dose. The continuation of the pandemic has really pushed healthcare organizations to their limits. And a lot of attention was drawn around supporting healthcare workers who really have bared the burden of the crisis, along with patients and their families. And some workers have even accepted additional responsibilities or even new responsibilities related to patient care. Thinking about those ambulatory care settings where practitioners now have been assigned more to telehealth and teletriage than seeing patients in person. Next slide. We still do have some supply chain challenges. We still are dealing with drug shortages. And as a result of the burden of the pandemic, we are seeing pandemic-related job losses. A lot of these staffing shortages existed pre-pandemic, but they've been worsened by the pandemic. There was a recent poll that was done in September of this year, and they polled healthcare workers, and the demographic of healthcare workers included physicians, nurses, nursing assistants, nursing home staff, healthcare administrators, other clinicians, healthcare clinicians, dentists, and they asked them a number of questions. There was 1,000 people total, healthcare workers total, that were polled. And one of the questions they asked was, since February of 2020, right at the beginning of the pandemic, have you resigned from a job? And 18% of those people surveyed said that they had resigned from a job. Another question they asked was, have you considered leaving your job since the pandemic spread to the US? And 12% of those healthcare workers said that they had considered leaving their job for another healthcare role. But 19% said they had considered they're leaving a job altogether and leaving healthcare altogether. Next slide. For those of you that might follow Becker's Hospital Review, and particularly the pharmacy Becker's Hospital Review, you might be familiar with a story that actually repeats. It's 10 hospitals seeking pharmacy leaders. And every week, the story's there. And what's interesting is that they can report on that every week. And secondarily, the depth and breadth of the organizations that are looking for leaders in pharmacy. JobRx in October said that more than 23,000 pharmacy jobs had been posted. And interesting, half of those jobs were for health systems. And when you look at the highest number of postings by subcategory, that was for pharmacy technicians. 52% of the jobs were for pharmacy technicians. So you couple this with the added responsibilities of our push for vaccination and vaccine expansion, the use of monoclonal antibodies, drug shortages that remain ever present, and how some of the priorities may shift to push more work towards pharmacy in situations where we cannot get certain medications or medication forms. And also, all of this is affected by staff shortages outside of the pharmacy. So next slide. Where do we have risk still? Let's take a look at risks with preparation of IV push medications. These are widely prescribed medications. Next slide. They are a common component of healthcare delivery. And we know that harm can result if these sterile products are not properly compounded and or administered. Now, I've italicized the word compounded here because a lot of times when we say the word compounding or compounded, we think of pharmacy. But compounding is not just a pharmacy thing, and it really includes any of the bullets I have here. If you're combining products, regardless of where you're doing it, if you consider something admixing or diluting or pooling, reconstitution, or just repackaging, moving something from a vial to a syringe, all of this is really considered compounding. Next slide. In 2020, during COVID, ISMP looked to our readers to get a better understanding of where organizations were with regard to the practice of compounding, including all of those things that I mentioned. And we looked for information about what was occurring outside of the pharmacy in care areas. And we heard from 444 practitioners. 3/4 of them were nurses. 8% of them were anesthesia providers, CRNAs or anesthesiologists, and 15% of the respondents identified either as decentralized pharmacy staff, physicians, or supervisors. And the vast majority of these practitioners were practicing in an acute care setting. Next slide. By far the most frequently prepared sterile injectable by these practitioners who responded to our survey was IV push medications. Most of this was transferred from vials to syringes. Some of it did include dilution, and the top drugs that they were preparing were opioids, antiemetics, antibiotics, and proton pump inhibitors. Staff also reported preparing intermittent infusions. Most of this was using those vial and bag adapter systems. And also the third most commonly prepared sterile injectables were intramuscular injections. And these were mostly vaccines, antipsychotic medications, and antibiotics. Next slide. We wanted to get a sense of the frequency of how often this was being done. And 58% of the people who responded said that they always or often admix, dilute, reconstitute IV push medications. 53% said they always or often prepare intermittent infusions in the care area, and 39% they said they always or often prepare intramuscular injections. Next slide. So compounding is also not without risk for error, and we wanted to get a sense of practitioners' knowledge of errors that might have occurred. And 31% of those who responded said that they were aware of or personally experienced errors when preparing or admixing injectable medications in care areas outside of the pharmacy. And you have to keep in mind that in this setting, often it's the practitioner who is preparing the medication or the solution or the dilution is often the one who's administering it. So there really is not another set of eyes ever on that process. The top errors that they identified were either wrong drug or wrong dose, wrong concentration, wrong diluent or wrong diluent volume. Next slide. There's also sterility risks when we look at compounding in care areas compared to the pharmacy. And this was the results of a meta-analysis of microbial contamination of parenteral medications that were prepared in a clinical versus a pharmacy environment. And the literature review spanned the years from 2000 to 2018, and studies had to report a contamination rate or a contaminated subjects as an outcome in order to be included in this meta-analysis. And what these researchers found that there was a significantly higher contamination rate for preparation of parenteral medications in the clinical environment as compared to the pharmacy. And the contamination rate of these studies ranged from 1.09% to 20.7%. And the authors, the researchers hypothesized that there were many potential contributing factors, including the environment in which this compounding occurred, the staff that were doing it, the training that they had received or not received, the frequency of them having to do this compounding, and also their ability to maintain aseptic technique. Next slide. There's also risks related to wasting IV push medications, which are often opioids. This was a study that was done with the primary objective to quantify the waste associated with administering select opioids IV push. And they looked at hydromorphone, morphine, and fentanyl. And in this study, waste included the amount of drug wasted and the time associated with the process. So it was the quantity and the workforce time. This was a direct observation time motion study, and they did it in inpatient care areas at 2 sites. Over a 2-week period of time, they performed 669 observations. And in that 2-week period of time, there was a combined loss of $1,600 worth of drug and a workforce time waste of almost $500. This is only a 2-week period of time. And the workforce time waste was nursing staff time that they quantified. So it averages about $2.40 per dose. And again, 2-week period of time only. Interesting, as secondary measures, in 86% of their observations, they found that nurses were interrupted in this process. And they also found that the average time from removal of one of these medications from a stock location to the time of disposal was 2 hours. Next slide. So what can pharmacy do to minimize these risks? You know, you might be asking yourself this question. You might think that maybe we could pull more compounding into the pharmacy department. In order to really understand how we can best address these risks, we need to really understand in our own organizations what exactly is happening and why. Why is that happening? Next slide. As part of that survey that we did in the midst of COVID, we also talked to pharmacy practitioners about compounding, and we had a very large response rate. And here you see again, most of these practitioners were operating in the hospital and pharmacy environment. And in their pharmacies, 57% were using some form of technology. Next slide. And we know historically from observational studies of manual compounding processes that we have about a 1 in 10 error rate for a compounded sterile preparation. We know that this has really been validated more recently when we looked at data from automation, and it's shown us that it's been able to identify a 7.1% error rate, so pretty close to what we had found when we did observational studies. We also know that when we compare manual processes to technology-assisted compounding, that the technology provides a safety benefit in that it can detect 14 times more errors. Next slide. When we talk to those pharmacy practitioners about compounding that's occurring in the pharmacy, we ask them about error rates, just like we asked the practitioners who were doing that in the care areas. And 3/4 of the respondents were aware of at least one compounding error in the last year. And that included those errors that were caught and corrected in the pharmacy, as well as those that had been caught after being dispensed. Next slide. And when we asked an open-ended question about the biggest safety challenge related to pharmacy compounding, the top challenge was related to the verification process and the inability to really accurately verify prepared products if using an indirect verification process, like a post-procedural check. Staff were also concerned about training and competency. And although 57% of the respondents were using technology, insufficient amount of technology was listed as a top challenge. Also staffing. People were very forthcoming with that, just not having enough staff to be able to do these manipulations, the space to do it, and the workload, that the workload is increasing. And I mentioned about drug shortages, which can actually affect a lot of that workload in pharmacy compounding. Next slide. One risk that does exist in all care areas that I haven't mentioned yet that's the potential for diversion in all settings. When we talk about these IV push medications, many of them are controlled substances. And we know by many accounts that the stresses of COVID-19 have exacerbated opioid use disorder. Statistics around healthcare professionals who struggle with opioid use disorder, it always seems to be 1 in 10 when we look at statistics, projections. People cite numbers between 10 and 15% of healthcare professionals will inappropriately use these substances over their career. However, a lot of people believe this number is underestimated. What is unique about healthcare workers is that their pattern of drug abuse and dependency is unique to the general population. It tends to follow the drugs that are available to them. They also have different job-related stressors, and we're adding those stressors of the pandemic on top of that. Practitioners in healthcare see the positive effects that these drugs have on patients, and they have a comfort level with their use, so they feel like they can be in control of it. There are a number of things that increase your risk exposure. One of them is routinely supplying more drug than what's needed. If I'm always giving a practitioner more than what they need to treat the patient, they always have extra. A second is allowing manipulation of the products, especially when it's not supported, where practitioners independently choose to perhaps dilute a medication without support for that or without standard processes that support that. And then the other area of risk exposure is the workflow required to close the loop. We have movement of these substances from one stock location to another. They're taken out of a location, taken to a patient, administered, and then there's some left over and wasted. It takes time to be able to close that loop. And if we are not closing the loop on a regular basis, we're really missing the opportunity to detect potential diversion. And that may also give people a comfort level that nobody's watching them and they continue to do it. Next slide. So what can we do now to support safe injection practices, considering, all of these disruptions and the pandemic related disruptions? What steps can we take? Next slide. So I talked about a couple things here. I talked about stressors and disruptions of the pandemic. I talked about changing responsibilities and shifting priorities, and particularly in the pharmacy, where we've got a movement towards vaccine preparation and administration, the use of monoclonal antibodies, drug shortages, and the potential for that bringing more work back into the pharmacy. I mentioned how we have changed how we care for patients, the donning and doffing of PPE, the changes to our mid-level safety strategy of independent double checks, and some of the trade-offs that we made due to workflow changes. I mentioned those documented risks around compounding or admixing or diluting of sterile preparations and patient care areas, and the errors that can result, and also the challenges for some of that work in the pharmacy. Diversion is also out there and being exacerbated by the opioid use disorder, being exacerbated by the stressors of the pandemic. And finally, the staffing component. The current state of 50% of pharmacy jobs being in health system, 52% being for pharmacy technicians, and the potential future state, thinking about those healthcare workers, that large percentage of healthcare workers, 31% collectively wanting to leave their job, some considering healthcare, some not considering healthcare at all. So what actions or decisions can eliminate risks and improve medication safety in light of all of these things that are going on right now? Next slide. Well, we've gained knowledge related to risks, some of those that have existed pre-COVID, some are exacerbated by COVID. And we really need to take steps to lighten the load on healthcare practitioners, while at the same time protecting them and our patients from being in harm's way. So some of you may be here with some of these recommendations. Some of you may be on your way or want to get here. Others may have tried to implement these recommendations, but maybe have felt some pushback. And it's probably a really good time to revisit some of these recommendations around eliminating the need for compounding and potential risk of a hospital-acquired infection by capitalizing on the purchase of commercially manufactured products. Removing the need for compounding outside the pharmacy environment. Remember that number one item that was compounded in patient care areas was IV push medications and the number one drug, opioids. So moving towards dispensing push medications in a ready to administer form, and reducing the steps required for wasting controlled substances by providing patient-specific doses in ready to administer form. So there's no extra drug available and no waste that's needed, gaining some workflow benefits for that. I think there may have been challenges to implementing some of these recommendations in the past, but in light of where we're at today, it's probably a good time to maybe push this envelope a little bit further. And I'd like to now call on my colleague, Michelle Mandrak, to come in, and she's going to take us further down this path of best practices for injection safety.
Thank you, Christina, and good morning and good afternoon to our attendees. It sure is a pleasure to be here with you on today's program. And we're going to now take a deeper look, as Christina has mentioned, into best practices for injection safety, specifically IV push medication use. Next slide. The COVID-19 pandemic, as Christine has really painted a complete picture, has really exhausted healthcare providers and staff alike, as I'm sure many of you are experiencing firsthand. The repeated surges have overrun the capacity of many hospitals and taken a dramatic toll on thousands of healthcare staff. The US Bureau of Labor Statistics estimates that the healthcare sector has lost nearly 500,000 workers since just February last year. And nursing shortages, these have been a challenge even before COVID-19. These have intensified. In September, in fact, the American Nurses Association asked the US Department of Health and Human Services to declare the current nursing staffing shortage a national crisis and to take direct action. This month alone in December, Indiana, Maine, New Hampshire, and New York have enlisted the National Guard to help staff healthcare facilities. Several states have enacted crisis standards of care, and this gives hospitals a framework to use in making staffing decisions during workforce shortages during these COVID-19 surges. But at the same time, crisis level staffing puts practitioners' ability to care for patients in jeopardy. It also is a significant source of moral distress for providers, meaning distress imposed due to being prevented from doing what you believe is right for the patient. Beginning earlier this year, Chris touched on it, a new economic trend coined the Great Resignation became evident in which US employees were voluntarily resigning from their jobs in large numbers. And yet, despite these significant barriers, patients still need care. And those who delayed medical visits over the past year and a half are trying to catch up on their care now. This just adds to the pressures that healthcare organizations face. Next slide. And it goes without saying that this new pandemic reality and the concomitant healthcare challenges that are associated create the very real and significant potential for errors. Next slide. So let's consider the impact of these current stressors and disruptions on medication administration. Nurses are the primary caregivers in hospitals, and they sure spend a lot of time on the critical task of medication administration. As such, efficiency and effectiveness of nursing care is going to be essential to both patient safety and hospital function. Nursing research studies indicate that nurses spend more than a quarter of their time on medication administration. Of note, though, in looking at the research is that most of the time is spent on obtaining and verifying medications. So basically more time is needed related to hunting and gathering of the medications, the supplies, than actually in the cognitive medication administration process. Henrik and Chow are nursing researchers who conducted a really important time and motion study across 36 hospitals. They were looking at how med-surg nurses spend their time. And their findings indicated that medication administration was a key target for improving the efficiency of nursing care. And this study was done well before the impact of the pandemic on this care. They found that about 2/3 of medication administration time was related to simply getting the drug to the patient, and the other third was needed for the preparation of the medication for administration. Increased nurse workload and this growing nursing workforce shortage reduced the amount of time, as we have shared, that's available for doing these patient care activities, not the least of which is the critical task of medication administration. And we recognize that the COVID-19 pandemic presents additional and significant challenges to organizational medication safety efforts. So let's look at some best practices around IV push medication use. Next slide. We see this as important because IV medications are an essential component of care, and they're known to be clinically advantageous because of their immediate therapeutic effect. But at the same time, and for much the same reason, harm can result from IV drug administration, again, due to the immediate bioavailability of intravenously administered drugs, and many of them have a narrow therapeutic dose range. We recognize that many high alert medications are also administered intravenously. And because high alert medications have a narrow margin of safety, errors with these drugs are associated with a higher risk of patient injury or death. For these reasons, IV push medication use warrants priority focus in organizational medication safety efforts. Next slide. Research has shown that the incidence of errors with injectable medications is higher than with other forms of medications. Studies suggest that half of all harmful medication errors originate during the drug administration phase. And of those errors, about 2/3 involve injectable medications. So this sort of overlays on what Chris has shared. Several factors can increase the risk of errors and patient harm with IV push medications, such as using part of a vial or ampule, or more than one vial or ampule to prepare a single dose. The need to have multiple steps or manipulations to prepare the drug. Vial to syringe transfer, certainly syringe to syringe transfer, dilution of a product, use of a filter. When there's a need to reconstitute a medication on the unit for IV push administration and use a specific diluent. And then the availability of having concentrated injectable medications on the unit where further dilution is required. Next slide. ISMP's 2014 survey specifically delved into these dilution practices before IV push medication administration. And we were delighted. This survey had a tremendous response, and it was our best one ever. It was completed by nearly 1,800 respondents. Most of those were registered nurses. And the survey results suggest quite readily that nurses frequently dilute medications. And this is a practice that may be necessary depending on the drug, but also one that may unnecessarily result in repackaging of pre-filled syringes that are provided by the pharmacy. This practice often has led to unlabeled or mislabeled syringes. Christina mentioned about contamination of sterile products. There's also the issue of dosing errors, not to mention just the time in the additional medication preparation steps. Overall, 83% of nurses responding to this survey reported that they further dilute certain IV push medications, and that was at a frequency of sometimes, often, or always. This was virtually unchanged in our follow-up survey in 2018, literally the same. Pertaining to the containers in which IV medications are provided, those medications available in single-dose vials or ampules were those most often to be diluted. And even when the pharmacy dispenses a pre-filled syringe containing a patient-specific dose, as many as 20% or more of respondents further dilute these medications. 5% would always dilute these medications. So we can see that further dilution of IV push medications is common on patient care units. And when asked about the dilution of specific drugs, opioids and anti-anxiety and antipsychotic medications were those most frequently diluted. Next slide. Now, some of the primary factors that influenced the decisions to dilute were associated with the interest in administering the drug slowly. That was the main reason, to avoid patient discomfort, reduce risk of extravasation, and to be able to measure small volume doses accurately. Numerous respondents provided reasons for diluting medications that may not be clinically necessary. Several respondents suggested it was just safer to dilute all medications before IV push administration, so that the drugs are always going to be administered slowly and thus enable the practitioner to feel more comfortable about patient monitoring. Others felt there was just no way to know how a patient would respond to a medication, or it may cause discomfort, so best to dilute all drugs. Several respondents also reported their practice of simply hanging a piggyback of normal saline to administer concurrently with the IV push medication. So this way they didn't need to actually dilute the medication. This practice just may not be appropriate without a prescriber's order. Next slide. For those who dilute medications, the survey asked respondents, well, do you have a standard volume of diluent each time for a specific medication? The response was nearly split, with just a little less than half, about 49%, indicating that the volume of diluent was variable, even for a single drug. We also asked for respondents to describe how they determined the volume of diluent to use. These responses were also highly variable. Most practitioners seem to have a personal formula. One that we saw a number of times was diluting such that I could give a mil per minute of the time needed to administer the drug. So for instance, if an IV push medication should be pushed over 3 minutes, the medication was diluted in a total of 3 milliliters and administered as 1 milliliter per minute. It was interesting that no respondents described a dilution process that would result in a specific concentration. For instance, adding 4 milliliters of diluent to a milliliter of drug, I'm striving to get so many milligrams per 5 ml. So as suggested by this variability of dilution methods and volumes by practitioner prepared syringes, less than half of the respondents reported that their organization provided them with policies or guidelines on dilution. Next slide. And when dilution occurs, most practitioners in the ISP 2018 survey, that was like 81%, described using a saline flush syringe for this purpose. So this is definitely an unsafe practice. This has increased since the 2014 survey. At that time, 54% of practitioners said they had diluted medications using a flush syringe. One possible reason for the increase may have been the shortage of vials of 0.9% sodium chloride at the time of the survey, which a number of practitioners noted in the comments section. About 56% of respondents said they use a flush syringe to dilute medications at least half the time. 19% said they always do this. And think about your own practice sites. Unfortunately, when describing this work, most participants did not include relabeling of the flush syringe. More than a quarter of the survey participants reported that they rarely or never label IV push medications that they have prepared away from the bedside. Next slide. So let's take a look at some specific issues with cartridge type syringes. Back in 2012, ISP conducted a short survey of frontline nurses trying to understand, for those who were using Cartridge pre-filled syringe cartridges, if they were concerned about the potential issue of overfill, in these syringe systems, and whether they were aware. And actually, nurses were not concerned about overfill because many of them described withdrawing dosage from the cartridges using another syringe. Comments implied that they didn't believe this was a significant concern. They were using the cartridge as more as a single or multiple dose vial than a pre-filled syringe delivery system. So you can see in the picture that the needleless adapter had been removed, and the nurses would access the medication in the cartridge syringe through that puncture site. What they use as a puncture site, where the arrow is pointing to. So we asked again about this practice in the 2018 ICP survey, and 2/3, 66% of participants reported withdrawing medications from a pre-filled syringe or cartridge and then transferring it into another syringe, and in which case they would administer some or all of this IV medication dose. About 16% do this more than half of the time that they encounter a pre-filled syringe. Next slide. So certainly there are multiple patient safety issues with this type of practice, including the risk of contamination, as Christina has already highlighted in discussion, around compounding risk. And this particular risk of contamination occurs when you're using these single-use cartridges, either as multi-dose vials or simply entering the cartridge because it's not intended for puncture as a vial. There's also the risk of unlabeled syringes when medications have been withdrawn from the cartridge into a new unlabeled syringe, or the risk of mislabeled syringes if the drug is withdrawn and into a flush syringe. Certainly dosing or measurement errors when transferring this medication contents from one syringe to another. One of the tragic things is the loss of the barcode. Here we have a product that's dispensed, that's labeled. It's typically a unit dose for an adult, and it's got a barcode, and now we can't scan it. There's also, as Chris alluded as well, in some of these practices, that these at-risk behaviors can facilitate drug diversion of products that may have been documented as wasted. In our surveys, nurses gave us some background as to factors that encourage this practice of withdrawing medications from the cartridges, most often citing the desire or need to dilute the medication. Interestingly enough, many respondents indicated that there was unavailability of the syringe holders, or they didn't even know of their existence, as well as that this is just the way they had been taught. Next slide. So despite its status as an effective method of delivering medications, IV push drug administration often poses risks because of its complexity and the multiple steps that are often required to prepare, measure, and administer the medication. Studies that have specifically focused on injectable medication errors confirm their high rate of occurrence, with an incident rate that's well above errors with non-injectable medications. In the study by the American Nurses Association related to injectable medications, 99% of nurse participants, and there was over 1,000, believe that the risk to patients is serious if an error occurs, and that almost half of the errors are likely to happen during the preparation and administration of these IV medications. What we do know from the published literature is that administering IV push medications too quickly is the most common type of IV medication error. These studies indicated that in anywhere from 43 to 69% of these IV push medication doses that were given too quickly were clinically significant. There's also wide variability in the rates of administration in these studies. And this is similar to what ISMP team members see in our on-site work at hospitals doing risk assessments. Giving IV push medications too quickly may also cause a patient discomfort or phlebitis or other complications. For example, in this reported event, now on the next slide, this is a case that led to a patient's death. An ED physician prescribed labetalol 20 milligrams for a patient who was coming in with hypertensive crisis. The nurse went to retrieve the drug, but the patient was already in the process of being transported to radiology. The nurse caught up with the patient on the litter, administered the medication literally in a matter of seconds. The patient actually immediately arrested and was not able to be resuscitated. Later, to the organization's credit, staff discovered several other cases where rapid IV push of labetalol may have contributed to patient harm. Next slide. IV push medications often require slow administration over 2 to 5 minutes. And 2 to 5 minutes can feel like a long time when administering a medication. Clocks showing elapsed time improved practice. Interestingly, we find staff administering IV push medications often in settings where there's not a direct line of sight available to a digital clock, or the staff member doesn't have a watch. This is likely compounded in settings in which bed capacity has been surpassed, as in these current surges, and patients are being boarded together in non-traditional locations. So let's touch on some of the concerns related to syringe labeling. Referring back to that American Nurses Association study that involved more than 1,000 nurses, they looked at the challenges of labeling syringes as part of this work, and these were syringes containing injectable medications. The survey revealed that more than 2/3 of respondents believed errors could be reduced with consistent syringe labeling. In ISMP's 2018 survey, which we have the responses here, the key responses on the slide, we see that labels on clinician-prepared syringes are more likely to be limited or absent. Only about half of the participants told us that they always label IV push medications that are self-prepared and away from the patient's bedside. I think we're a slide behind, at least on my screen. Okay, there we go. Thank you. Comments suggest that labeling was sometimes accomplished by taping the vial to the syringe, and more than a quarter of participants said they rarely or never label these syringes. Next slide. So lack of labeling certainly poses risk of error, as in this event reported to ISMP. A syringe containing the neuromuscular blocking agent vecuronium was prepared for a trauma patient. Medications not used, it was not used, and the syringe was set down near saline flush syringes that had been drawn up by the staff. The vecuronium syringe ended up being later used to inadvertently flush an IV line of a 3-year-old. This child, stopped breathing, had to be intubated, fortunately, because she was in the ED. That was done rapidly and no permanent harm had occurred. Next slide. So let's look at the reasons practitioner prepared syringes were not being labeled. Participants who said that they didn't always label syringes that they had prepared away from the patient's bedside, they believe that labeling was just not necessary if they were preparing one medication or one syringe. Surprisingly, 7% of participants said that they could distinguish between multiple syringes that were unlabeled simply by the visual appearance or location of the syringe. So how they did distinguish between 2 or more unlabeled syringes was a couple ways. There may be different volume of medication. There could be different size syringes, difference in needle caps, colors of the syringes themselves, the way the staff member oriented them on a tray or the sterile field, or they may carry different medications in different hands or different pockets. So obviously risky practice, by these practitioners, but they felt that they were in a safe place. Next slide. Think about how much practitioner preparation of IV push medications is being done on patient care units in your organization. And also consider the degree of medication syringe preparation by providers in OR settings and procedural areas. Our survey results suggest that clinician prepared syringes are common. Going back to the ANA study, the American Nurses Association study, about 44% of the nurses said that they were administering medications via syringe more than 5 times each shift, and 1/3 administered injectable medications at least once each shift. Most participants in ISMP's recent 2018 survey indicated they don't receive IV push medications in ready to administer syringes, and that was specifically 75% reporting that less than half the time IV push medications were provided in pharmacy prepared or commercially available syringes, so that they must prepare these syringes themselves. And that has probably become more common, during persistent drug shortages. Next slide. Now, ISMP published its safe practice guidelines for adult IV push medications back in 2015. The guidelines were developed to help healthcare facilities standardize safe administration of IV push medications, as well as to prevent unsafe practices and at-risk behaviors, such as those that we've been going through today: unnecessary dilution, absent labeling, giving IV medications too quickly, drawing up medications in flush syringes, and unintended use of cartridge type syringes. The consensus statements presented in this guidance document are based on a summit that ISP conducted with key stakeholders back in 2014. And this reference is available at no charge. If you're not familiar with it, it's on our website in the guidelines section. The link is provided here. Within this set of guidelines, there's 31 statements divided into 8 categories as on the slide, each addressing key risks that were identified at the summit. Next slide. Now, Christina asked us earlier, what steps can be taken to support safe injection practices? And in these final slides, I'd like to provide additional detail on these key safe practices for IV push medication use, particularly thinking in this context of the healthcare challenges that you are currently facing. And when we do look at methods to eliminate errors, to make them visible, to at least mitigate the harm, we recognize that risk associated with medication use is really going to be controlled by one safety strategy. A more reliable approach is to employ a combination of strategies to build your safety net. Some of the strategies are considered stronger or high leverage because they have a reliability to consistently impact safety. And those at the top of this list are just examples of strategies that are considered high leverage. And that's because they're not dependent on human vigilance to be successful. Now, strategies towards the bottom of the list are necessary for building that safety net, but they're not as strong as those at the top of the list because they're going to need to rely on human memory and behavior to be effective. So that's why they're considered lower leverage, because we need individuals to do the right thing. And we just don't want to rely on low leverage strategies alone, the rules, the policies, the education, when implementing safety strategies. So when selecting these strategies, choose multiple and concentrate efforts on capturing as many of the high leverage strategies from the top of the list. Next slide. Probably one of the most important points Christina and I want to share today is that providing IV push medications in ready to administer form is a key high leverage strategy to reduce risk of errors with IV push medication use. Having a commercially prepared or a pharmacy prepared product that's labeled, that has that barcode and ready to use just minimizes the need for practitioner manipulation outside the pharmacy. As mentioned earlier, research has shown us that the incidence of errors with injectable medications is much higher than with other forms of medications. And we know that it's that need for multiple steps or manipulations to measure these partial doses, reconstituting, diluting, that create significant factors which increase risk. Providing IV push medications in ready to administer form avoids unnecessary error-prone complexity, and it also promotes efficiency, which would simply be very welcome, in these current environment. ISMP has long promoted the provision of medications in a ready to administer form. And this strategy was actually the first safe practice in our safe practice guidance document. Other professional organizations promote this key safe practice, including the Infusion Nurses Society and their infusion therapy standards of practice, ASHP and PPAG in their guidelines for providing pediatric pharmacy services in hospitals. As you likely are aware, the Joint Commission includes dispensing medications. The most ready to administer forms as commercially available are included in its medication management standards. We do recognize that concerns have legitimately been expressed about barriers to achieving this strategy, including unavailability of the pharmacy 24/7 to prepare these medications, the cost, the shortages perhaps of commercially available products, and maybe even the lack of approved stability data. However, it is important that this safety strategy continue to guide organizational strategic planning efforts for IV push medication use. Next slide. Now, here are some mid-level strategies that tie into some of these issues discussed today. These include providing the rate of IV push medication push administration on the MAR. So it's available to the practitioner at the point of administration. Remember, the most frequent error with IV medications is administration too quickly. Providing clinical units with preprinted, ready-to-use labels, including those sterilized labels where they're going to be needed, can support safe labeling practices. And again, establishing standard workflow to have practitioners appropriately label their prepared syringes, unless that medication is prepared at the bedside and it's immediately administered without a break in the process. We do know that this labeling practice is an area of opportunity. We've seen in the surveys from ISMP and ANA that it's a frequently inconsistent practice. Now, having clear organizational expectations that IV push medications are not withdrawn from commercially available cartridge type syringes. It seems like blasphemy. You would not use these syringes as intended. And then incorporating standard practices for IV push medication preparation that don't include diluting or reconstituting IV push medications by drawing them up into flush syringes. Next slide. And now lastly, important, although lower leverage strategies for safety as well as efficiency include giving practitioners the instructions and the access to the proper diluent when reconstitution or dilution is necessary outside the pharmacy. Some organizations, this looks like pharmacy prepared kits, while in others, this information is available in an expanded view as part of the MAR entry. Providing standardized, approved IV push medication resources at the point of care, which can guide IV push administration. You can see a template, to the left. Resources like this should include special considerations for preparation and administration, and for those unique practice locations where these medications may be safely administered to really ensure that the patient can be effectively monitored. And then lastly, establishing practice that IV push medications are only going to be diluted when it's recommended by the manufacturer, is supported by the literature, or it's in alignment with institutional guidelines. Because we know dilution of medications may be required by the manufacturer, but whenever possible, this should occur in the pharmacy before dispensing the medication. And with that, I thank you and turn it back to Christina.
Well, thanks so much, Michelle. We are at the top of the hour. I'm going to ask Jordan to give us the next slide so that everybody could get the CE information. Remember, if you are a nurse looking for continuing education credits, please visit www.ismp.org. Under the link for this program, you will see how to obtain your nursing credits. For those of you that are looking for pharmacy or pharmacy technician credits, this is the attendance code on the slide here. It's also in the handouts if you've downloaded the handouts. Please visit proce.com in order to obtain your statement of your credit and attest to your statement of completion. We want to thank everybody for joining us today and hanging with us. We see your comments in the chat. Thank you for those. We do see some questions, and we will do our best to reach out to each of you directly who've asked a question. So thank you very much, and we hope all of you have a wonderful rest of your day.